Hello and welcome to Dragon Bites, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the presenters at Dragon Bites and a paediatric trainee based here in Wales. We've been very fortunate this week. Dr. David Evans, Vice President of Training and Assessment with the Royal College of Paediatrics and Child Health, has kindly taken some time out of his busy schedule to have a chat with us about the impact that COVID has had on paediatric training in the UK. Stacey Harris, one of our regular presenters, is joined by Hannah Davies, one of our newest presenters, who's doing her first episode with us to have a chat with Dr. David Evans about these issues. So hopefully this will answer a lot of the questions that trainees will inevitably have about the effect that COVID is going to have on their training. Anyway, take it away, Stacey.
So thank you very much, Dr. David Evans, for joining us today. You're the Vice President for Training and Assessments for the Royal College of Paediatrics and Child Health. And we wanted to talk to you today a little bit about training and the impact of the coronavirus on our training, really. I suppose we understand how it's affected us individually, but it would have affected different trainees differently. And given your role, you have the best overarching view, I suppose, of how it's affected trainees in general. I was wondering if you could briefly summarise the key points and the key things that has affected trainees during this time.
Yeah, okay, thanks. Well, you're definitely right in that it's affected trainees in many different ways. I think it's probably safe to say that there are very few trainees it hasn't impacted, but some have been impacted much more than others. And I suppose, as a general principle, it's possibly has the potential to impact those trainees who are closer to finishing than other trainees. Um, we've got a great advantage in the paediatric curriculum in that it's a new curriculum and it defines the outcomes. So that's why we call it an outcomes-based curriculum, and it's not based on time or having to do certain rotations. So it means that if the rotations are impacted and you haven't been able to do certain things, certain jobs, it doesn't necessarily mean that you won't get there in the end, because after all, it's the outcomes, what you need for a CCT, which is the key thing. There are a number of trainees, though, who are coming up to the end and they're expecting to CCT at the end of this year, so sort of August or September. And some of those were due to do the START assessment that was in April, and that unfortunately got cancelled. And so they're in the situation where they want to finish, but they haven't done their START assessment. Now, we know the START assessment is a formative assessment, but it's still mandatory. The GMC require every trainee to do it. And our next planned start is not until October. Yeah. So we've been working quite hard to try and see if we can come up with a solution for those trainees. And we think there's about 20 trainees involved, and we've asked trainees to let us know. We've asked heads of schools and all the CSACs. And what we're hoping to do is to run a remote start, probably based on a reduced number of scenarios, just for those trainees to start with, so that we can get them through their CCT. And so those are the ones who have probably been impacted most, and hopefully we can mitigate against that. There will be some trainees, though, perhaps doing subspecialty training, who found their training quite disrupted because a lot of the services have been shut down effectively. So there have been quite a few cutbacks in community services during the sort of redeployment. So trainees may have been redeployed, or their clinics may have stopped actually running. There's quite a few subspecialists who might have gone to certain types of clinics, outpatient-based clinics or procedures such as endoscopy, and that has been curtailed. Now, we hope that those services will be restarting, but they're probably going to be restarting on a rather reduced capacity because of things like social distancing and rearranging the departments. And so it may take some time for those trainees to get that experience ready for their subspecialty recognition. And as I said, it's probably going to affect those trainees who are closer to the end, because there's not so much time for them to have it made up for them. So you can imagine if you're in your first year of subspecialty training and you miss out on some aspects, you've got another sort of 2 years to have those learning opportunities re-provided. And we'd hope within 2 years there'd be, even in the new normal, even if there's not a vaccine, a lot of activity has to pick up because we are looking after children who need those services. So I think those are the ones who are perhaps most worried because they can see their certification and therefore getting a job being at risk because of the immediate impact which is happening just at the end of their training.
And David, you said you were having meetings with the GMC about the remote start assessment. Has there been any updates about that at all?
Well, I think the GMC are very open to solutions, and until we give them a concrete proposal, they're not going to give us a concrete approval. They're going to be, they're the regulator after all, and they're going to be quite careful to make sure we stick with the standards, and if we do reduce the number of scenarios, we can assure them that we're not compromising patient safety and those sort of things. But from preliminary discussions, because in a way we wanted to try and see, was this something that was worth us working up, as it were, or if it was going to, if it was never going to be approved, there wasn't much point. But I was encouraged that the GMC were open to these suggestions. So I think now the sort of ball's back in our court, really. So we've been having a meeting this morning about the start for the 20-odd trainees, but also thinking about start in October as well, because I think when we go to the GMC, we'll probably have two proposals: those for the small number of trainees who need start before August, September, and also what's going to happen going forward, because we plan to run start in Manchester. We have our circuits. Lots of trainees come in and they meet lots of assessors and they walk from room to room. Probably pretty good ideal spreading ground for virus. So we can't do that anymore, and some trainees will be shielding. We don't know what the transport links are going to be. There may be another surge. So we can't depend on running start as if it was last year. So I think part of the discussion this morning was also about what a new look start would be like before we can go back to what we would like. And so I think there will be a series of proposals to the GMC.
Do you see more virtual assessments and interviews in the new horizon with paediatrics going forward?
Undoubtedly, and I think it sort of it reflects more interviews and remote consultations with parents and outpatients and those sort of things too. So I think it is going to be the new way of working. I think we also had an impact on recruitment, of course. We'd done our ST1 recruitment, but we were about to recruit for 3 and 4, and also the re-advert for 1, and the lockdown happened just at that time, and it didn't really give us sufficient time to do any remote recruitment because we needed to do it within a week or so. So those trainees have been appointed on the basis of their application, and that's been the same across other specialties as well. But I'm thinking, our next round of recruitment will probably be for subspecialty recruitment, so grid recruitment, and I can imagine that will be a remote basis.
So there is that to go ahead this year, just more virtual based.
Yes, I mean we will undoubtedly recruit to grid. Whether the interviews will be exactly at the same time, or they may be a bit later in the academic year, so they might be in 2021, early 2021 instead of late 2020. But we're learning quite a lot about how other institutions work as well. So, when we do our exams, we use suppliers that are used to looking after exams for other agencies, and they've got quite a lot of technical expertise, and also a lot of the universities, of course, have had to do their medical student finals and various exams remotely, and so there's quite a rapidly evolving body of experience on how to run assessments. Um, and I think that's something we've got to get engaged with, really.
Yeah, it's pretty fascinating, actually. How quickly everybody's learning and how to change given the coronavirus. If a trainee's been redeployed to adult medicine, then that's going to be quite difficult for them to get their competencies signed off and things like that. So would they be expected to do their post again, or would they have to do their post maybe in a shorter period of time and try and get the competencies more quickly? What's the
So it's quite difficult to cover every individual circumstance, but as a general principle, again, a lot of well, from my experience, many of the staff that were redeployed were relatively junior for my own trust, for example, because they were a bit closer to general medicine than some of the senior trainees, and certainly a lot closer than the consultants. Now, they would therefore have more time to pick up their paediatric capabilities. And I think the other thing that we have encouraged quite early on is to say, well, actually, if you look at the capabilities, a large number of them are shared across all the specialties. So, we restructured the curriculum into our 11 domains, and there are some domains which are fairly specific, but many of the other domains are not. So we've got teaching, we've got research, we've got leadership, many, and professionalism. Many of those are just as applicable in other walks of medicine. And so I think we've been trying to encourage trainees where possible is to look at their experience and think, well, what have I learned from that? And I think quite a few people have said, well, actually, when we've been redeployed into adults, we've sort of seen how the adult world works and how they've reconfigured the hospital and how they've made these different teams. And what I'd encourage people to do is actually reflect on that and say, well, what aspects have I seen that I could bring back into paediatrics? And I think there may be quite a lot of cross-fertilisation there.
Yeah, it's a great opportunity for learning from other departments, isn't it?
Yes, yeah. And of course, there are quite a few trainees who have been shielding for various reasons. And they may be feeling slightly frustrated as well because they're not in a patient-facing role. But again, it might be time to think about doing some projects, some audit projects, writing some guidelines. There's been so many guidelines to write, invariably with the words COVID in the title. Lots of reconfiguration. How do we do this? What about having a patient pathway? What happens if a child needs resuscitating in the middle of the ward? There's lots of things they could think about and contribute to. Also, many of our teaching programs have been disrupted, so we're now thinking about how to re-provide that teaching and learning and re-provide it in an electronic form. So if somebody's shielding and has got an interest in medical education, they could think about, well, how can I turn some of the teaching sessions that we normally run, how can I turn them into a sort of electronic form or remote form? How can I come up with some sort of e-learning substitute? And of course, yeah, sorry, those sort of things would be very, very useful for a CV going forwards as well, because they're sort of distinct projects that you've done, you've had the idea, or you've worked in a team, and so they're very valuable actually for a CV.
The teaching has actually progressed quite quickly in Wales, and at the moment we've got virtual teaching pretty much every day going on, and it's all Wales, and we can log in at 1 o'clock every day, and there's teaching from one of the units, and it's providing teaching everybody,
Yeah,
because obviously we can't get together
yeah.
for our deanery teaching, so that's kind of substituted it, but it gives the option for people who are shielding and those on maternity leave to still engage with the teaching programme.
Yes, well, I mean, that's brilliant. And you might think about how you might supplement the teaching, because as you know, if you use any teaching method, it will always have an advantage in one respect, but there'll be a disadvantage in another respect. So there'll be certain people who might not be able to engage so well in the teaching, or certain subjects that aren't so well provided by that type of teaching. So, I'd encourage people to think about, well, how can we've managed to move it to an electronic platform, but how can we sort of provide that interaction? And I think a lot of teaching has sort of moved from being centered around an event. And so what you might have is you might have an initial presentation, but then you keep the forum open, and you keep a sort of moderated chat, or you try and spread the teaching across the week rather than just around that one event. So there's lots of things people can do.
There's one thing that we've been doing as well in Newport, Stacey. I don't know if you want to talk about the COVID-based teaching.
Yeah, so we've been doing we actually got the idea from another unit in Wales. Yeah, it's a really short teaching session based on it's COVID, so I think it's case orientated, very interesting discussions. Really good,
Very good, very good.
of just getting more teaching into our day-to-day life, and
Yeah.
but in kind of very informal, and it can be as quick as you like.
I was about to say it should be in 19 minutes, surely.
Yeah, that's a good idea, actually. Yeah, might have to add that in.
I was just wondering as well, David, I follow you on Twitter, and you mentioned this interesting, the 3 side effects of COVID that you saw. That number 1, everyone will value trainees as doctors. Number 2, ARCPs will become less bureaucratic. And number 3, that educational supervision will become centred around support. I was just wondering if you wanted to elaborate on that and give us a bit more information.
Well, it's great you reminded me, because I was thinking, oh my goodness, I can't remember what I wrote now. Well, I certainly think that one of the things about training is that I was very impressed in a sense that, of course, when there's a crisis and you need lots of highly skilled, highly adaptable people, then the trainees are the perfect people to go and man intensive care units or ED or COVID wards, and it just shows you how the hospital have suddenly realised that how adaptable and quick learners trainees are, whether they be paediatric trainees or other trainees. So that, I think, that was part of my thinking about people who actually start to value trainees. They're now doing something that's vital for the health service. It's not just their trainees. They are actually young, adaptable doctors. So that was very much the first thing, valuing them as doctors, what they can actually do, not just they're stringing along to the service and being trained. I think the second point was the ARCP. So I think when I wrote that, I was aware that it was going to be very busy. Now, at the moment, the peak hasn't been as bad as we thought, and touch wood, hopefully it'll stay fairly low, but I'm sure we'll have a bit of a bumpy ride. Yeah. And I was anticipating that people would be pretty busy, and so not so able to polish their portfolios, and also educational supervisors wouldn't be that available to do lots and lots of reading and going through the portfolios. So I thought, actually, well, what it will probably do is concentrate the mind on what do we really need? How do we judge whether a trainee is a good doctor and can progress? And so can we therefore get rid of some of the other things and actually measure what we really value? So that's what I meant about ARCPs becoming a bit less bureaucratic.
Yeah.
And one of the things we've done for the COVID, as you've probably been aware, is there's a new COVID educational supervisors report for ARCP. and we have actually slimmed that down a lot, and we've also slimmed down the assessments required for each trainee to progress just for this year.
Yeah.
And we've done that in that sense. We've slimmed it down to pick out the things we think are of best value in predicting how a trainee is, and how valuable the trainee is. So the last point was about educational supervision, and I was thinking that, well, this has been a pretty anxiety-laden time for everybody, really. So I think it's very important that we all support each other. And that my hope was that education supervision would be less worried about the bureaucracy of things and more concerned about the human nature, and looking after the trainees individual. And I think we were just talking before this podcast about being stuck at home and then actually going to work is actually quite a bit of a release, because you start to see more people, and it's actually quite nice to work in a team. And I think as doctors, although going to see patients and the thought of COVID being in the clinical environment is a bit anxiety provoking, it's still nice to see people, and that human touch is what keeps us going.
That's one thing
So
I've actually really missed, is
yeah,
just seeing everybody's faces and catching up with everybody.
that's right. Yeah. And I think education supervision, hopefully, when we all reflect on this from an education point of view, we'll sort of see, well, trainees, yes, they were really valued because see what they did. And ARCPs, we managed to cut down some of the bureaucracy, but we still maintain the value of it. And actually, the most important thing about education supervision is the sort of personal support and developmental support, and not necessarily filling out all the forms.
Do you think that's something we need to emphasise and work on, working towards the future, that this becomes more of a staple part of the educational supervisor role?
Yes, I think many supervisors have got those, have got buy into that philosophy, um, but I think sometimes it can be quite difficult to do it if there are lots of bureaucratic forms and lots of different things to fill in. And so I think that the whole COVID pandemic really has perhaps made us reevaluate what's important in life, and that's both in education and medicine and in general, I think.
Yeah, I think there's definitely, like, don't get me wrong, there's lots of negatives of what's happened with COVID, but I think it's
Mm.
also made us reflect on the importance of each other and team and well-being, and I think that's a massive positive.
Yeah, and the college have got quite a big interest in well-being as part of sort of recruitment and retention campaign. So, we're aware of the numbers of pediatric applicants falling over the years, and so we've had a recruitment campaign. But we realise that there's no point in recruiting people unless you can retain them.
Yeah.
And so there's been a bigger focus this year and on the in forthcoming years on thinking about well-being and what does that mean, and I think it means different things to different people. And so
Yeah.
it's not a question of just providing yoga to everybody or whatever. It's a thinking of what keeps people going, what support do they need, and that's a different for different personalities and also for different stages of your life, both your personal life and also your professional life.
Yeah. And with regards to recruitment to potential paediatric doctors, obviously some people have been denied the opportunity to work in paediatrics before applying to start the paediatric program. Is there anything put in place in regards to the applications, or are people being penalised for not having the paediatric experience at all?
Well, I suppose the short answer is in all the recruitment questions and the scenarios and the way we mark during the interviews, we've been very careful not to score people on paediatric experience, but more their aptitude generally, and whether they would make a suitable paediatrician. Um, Now, I do understand that for people to make a decision about what pathway would they like to do, they often value having the experience first, and also having the experience means that they can see the patients and they can see the teams and who they're going to be working with, and so it can enthuse them. But I want to be reassuring to people applying to paediatrics that what we're looking for is potential paediatricians. What we're not looking for is experienced paediatricians. And it's the ability, I think paediatrics is just as academic, it's just as needs critical thinking, it needs powerful diagnostic abilities, as well as communication skills, etc., etc. And if you've got excellent skills, then you would make an excellent paediatrician. And we're looking for those skills, not for the fact you've worked in paediatrics before.
Great. That's really good to know, and hopefully that'll reassure some people who've missed out on the opportunity in foundation training to have those opportunities.
Hannah and I have both listened to your webinar that you did at the beginning of this month, which actually answered quite a lot of the questions that we had for you with regards to missing exams, as I understand that you're planning to try and do as many exams remotely, and the logistics of that hasn't quite been worked out yet. Is that right?
Yes, that's a sort of the understatement. I'm sighing because we're just starting to grapple with that. Particularly, I think the most difficult question is the clinical exam. So as you know, we already have a system of computer-based testing for the 3 components before you do the clinical exam. Now, there will need to be some changes for that, because at the moment they're delivered by various centres around the UK and people travel to them, and we would probably look to see what options are available, whether we have more sort of secure centres, secure in terms of sort of hygiene and make sure things are disinfected and that computers are spaced, but also options for people to undertake the assessment and the exams remotely using their own computers. And this is where we have looked at and spoken to people who've used that for things like medical student exams and theory exams. And there's the terminology we're using is remote proctoring, where you can undertake an exam in your own environment at home, but you may use your mobile to film you doing it, so that the invigilator can be assured that you're not looking up all the answers or you're not googling things as you're doing the exam. So the theory exams, technology will help there. We were just sort of starting to think about the clinical exams, and you might say, well, why didn't we think about them earlier? Well, I think the situation wasn't very clear earlier on, but I think now it is clear that it's going to take a long time before we can get back to normal. And I think, again, we need to look at a range of options for clinical and try and reduce the requirement for NHS premises and possibly the requirements for patients as well. Many of the paediatric patients who are well known to centres that come and do exams, they may well be the sorts of patients that would be shielding. So we wouldn't be able to rely on those. And perhaps we may have to substitute other things that might reflect how we're changing our approach to clinical medicine anyway. So we were talking about, well, what about having a station where you have a remote consultation with a patient, over Zoom or whatever, or there may be consultations where you have a GP referral, and the idea is how you support that GP managing the patient at home, which is what we would want as well, and how you would triage. So I think that there are lots of challenges, but part of the challenges will be opportunities as well. And so I think the clinical examination, is perhaps the less well worked up proposals at the moment, and that's one of the tasks to start thinking about in the next few weeks, really, as the exam exec meets. And I think we are keeping an eye on some of the other colleges as well, to see how they have approached it and how the GMC have engaged in that process. So you may be aware that the GPs had to cancel their exams halfway through their clinical exams. And so there's a huge number of GPs who can't finish and therefore can't get a GP job until this has been sorted. So the GP college are looking at different ways of doing assessments, some of which we can learn from, but other bits aren't really applicable to us. But it's one of those questions of looking at all the various colleges, seeing the approaches and trying to pick what would be more appropriate for us. Potentially using it to improve the exam in some respects, move forward in a technological point of view. But also we have to realise that maybe we can't use patients as well as we might for these next number of diets until we get a vaccine or until the virus is controlled or whatever. So it's being adaptable really and looking at again at the range of options. So I think our next UK clinical exam is October, so we need to have something in place for then. The GMC have agreed for our proposal that for ST3 trainees who haven't yet got their membership, they can progress to ST4. That's not a problem. They would get to a COVID outcome of a 10.1, which is a no-fault outcome, saying that the reason they didn't get an outcome 1 is because they were unable to take the exam because of the COVID restrictions. But that can't go on forever. And we'll need to move ahead with exams. So, but they will be a bit of a changed, a changed format from before.
Oh, that's really, really interesting, actually, and there's lots of things that I'd not considered before. So we were going to ask about grid and spin applications, and you said that will be going ahead, but hopefully in perhaps a different format, more virtually. Is that right?
Yes. So we do need people to enter into level 3 training. So we will be doing some sort of grid application process. It will probably be some form of interview or remotely. Before COVID came about, we were looking at actually delaying the grid interviews a bit later into the academic year anyway, so that trainees may have a bit more time to prepare. And one of the reasons was part of our changes with Shaper Training, which may be a couple of years hence. What I wanted to try and do was introduce some element of flexibility so that trainees, if they entered a grid and they felt that actually that it wasn't quite right for them, they could move from one grid to the other, going through an interview, but they could move from one grid to the other and they wouldn't necessarily need to extend their training because quite a few of the grids have quite similar curricula. Or they share common curricula. So, for example, if you're a neonatologist, you can do a 6 months in PICU and 6 months in cardiology. It would still count towards your neonatal grid. So if you started off in PICU, you could probably swap to neonatology and it wouldn't affect your CCT date. But it's very difficult to make the decision to swap if the grid interviews are in November when you've only just started the grid in September. So one of the drivers for moving the grid appointment, later in the year, was to give people a bit more flexibility and a bit more time to prepare. So we'd probably open the application around the same time, but there'd be a much longer window for people to consider their application. And we may do this year. That's something to be determined, really.
I think that later grid application process sounds like a really good idea, actually.
Yeah. So I think there was reasons before COVID to try and do that. So maybe COVID might be just one of those things that just hastens the change.
And we talked already about how interviews will probably go ahead, but perhaps virtually and on of a slightly different format as well, didn't we?
Yeah.
So, and then we also talked about the beginning of this, the impact on CCT, and that people further into their training, this probably will affect them most. But you're trying to arrange some start examinations, which hopefully will be virtual, perhaps delayed. Is that right, after CCT?
I think that was perhaps one of our first plans, was maybe we could give a CCT and then complete start afterwards. But I think that's probably not the best solution. The best solution is to try and get people through the start assessment so that we can give them a CCT and they'll feel that their CCT is a normal CCT, it hasn't been devalued and that sort of thing.
Okay.
And because at the last count it was about 19 or 20 trainees, we could probably offer slightly more of a bespoke solution to those trainees. But then, of course, for October start, we know that 168 trainees were cancelled, so we'll have to catch up on the backlog and all the social distancing and the things we talked about mean that start may well have to change and incorporate some element of remote working.
Yeah, wow. Okay. Yeah, it's a lot to think about, isn't it? You poor thing.
Yes.
So I suppose I was really interested to hear about sort of how to get the most out of our training during this time. And I know
Yeah.
it's going to be different for different people, and different people will be getting a different training experience to others. But and we did touch on this a little bit at the start, but how can we make the most out of our opportunistic training experiences?
I think there's lots of ideas, and I was just musing to myself as you're asking the question. Really, I think sometimes when you are perhaps a relatively junior trainee, you get redeployed to adults. You feel sort of slightly cut adrift, and you perhaps don't realise that a lot of the experiences you're getting are excellent learning opportunities, but very, very relevant to paediatrics as well. As I said, it's about working in teams. There'll be leadership elements to it. There'll be talking to families. There'll be breaking bad news. There's lots of safeguarding issues now. I think adults have caught up in terms of safeguarding. There's issues with dementia care and capacity issues. So things that are very, very applicable to paediatrics. Where I fear there's a problem is not the fact that the learning opportunities aren't there, but people won't realise the learning opportunities are there. And this is why I think it's important to keep in touch with your educational supervisor, who's a paediatrician, during the time when you may be redeployed. And perhaps, just have a little chat every so often and perhaps, relay some of your experiences. And I think part of the role for the educational supervisor is saying, well, actually, that experience isn't dissimilar to something I had to handle, last year. Okay, it's an adult, but the actual the crux of the issue here was to do with their capacity and the fact the extended family wanted one thing, there's a conflict of interest. That's just very, very applicable in paediatrics. How about reflecting on that and drawing out the similarities between adults and paediatrics, but also looking at the differences between adults and paediatrics? And that would be quite a powerful learning opportunity, but only if you realise it. And I think that's the main issue.
I think that's where reflections are going to play a real key part at the moment, is just putting in your ideas, your thoughts and your feelings of encounters that you've had, and being able to come back on them and interpret them and make them relevant to our paediatric experience is going to be crucial.
Yeah. No, absolutely. I think my advice is just to jot something down. Don't sort of aim to produce a finely polished piece of reflection. Just write something down in the time.
Yeah.
There's a form on the e-portfolio. Just jot it down on that, and then go back to your education supervisor and say, well, these are all my little sort of half or quarter filled out forms. Which do you think we should develop, and what do you think? So get something down on paper or electronically first, and then deal with it later.
David, I know that some of the middle grade staff were quite concerned if they were redeployed to adults about, not having had any contact with adults for quite a while, especially adult medicine. And I was just wondering, was there any guidance prepared by the college in regards to protecting us or giving supervision to the adult medics who would be looking after us in regards to looking after our educational needs?
I don't think there was anything specific. I think what happened was most of the redeployment was handled via the postgraduate deans and the trusts. So I think whenever there was a request to redeploy trainees, the postgraduate dean had to look at whether they were suitable to move, and also to be assured that there was sufficient support, both from a pastoral sense, but also from an educational sense, and also a clinical supervision sense, that those trainees wouldn't be put in a vulnerable position. And my own trust ran quite a few sort of teaching, team building things, and it got people sort of induced into their team well before any patients arrived. And I think by and large, from what I heard, but obviously I didn't do a systematic survey of the country, I think many trainees felt reasonably well supported to start with. Now, I think we do have a bit of a problem at the moment. Not that they're unsupported, but I think quite a few trainees are still redeployed because there's been a nervousness about whether there'll be a second wave as the lockdown is being eased. And I think we're quite keen that the trainees come back to paediatrics as soon as possible, rather than twiddling their thumbs, in empty wards just because people are worried that there might be a second wave. Our own trust have released our trainees back to us with the proviso that should they be needed again, of course, they would be redeployed.
The other question I had, David, was with online and virtual learning resources becoming more and more prevalent, is there any that you'd recommend or that you found that are good for the paediatric training programme?
Well, I suppose there's lots of things you don't want to name check necessarily, people, but I find Twitter a very useful source because you get signposted to a lot of educational activities. And both from a sort of scientific point of view, so many of the papers that are published about COVID, people will tweet about very early on. And then there are lots of organisations, and of course Dragon Bites is a good example, but things like Don't Forget the Bubbles and lots of those, because there have been people who engage in Twitter tend to be the ones who are quite tech savvy and will produce good quality resources that can be accessed. The college have having to re-look really at their educational provision, so educational provision rather than educational supervision, so that this is what training materials we offer, and that's not just to trainees, but that's to every paediatrician. So we run lots of courses, the how-to courses and safeguarding and lots of things. And of course, we can't base those around events anymore, and we're having to change how we provide those and provide them in more of an electronic format. But those sort of courses, I think, will take a bit longer. So I think there should be a second wave coming, maybe in the next few months or so, thinking about some of the re-provision electronically from the college.
Thank you, David, for very informative answers to the questions that we had. I just thought we'd go to final thoughts, really. So, what are your main messages to trainees at the moment?
Well, I think my first message to trainees was don't worry, and don't worry about your training. And I think that still holds to a certain extent. What I've tried to do is to reduce some of the barriers to progression. But that doesn't necessarily mean that I don't appreciate there's been problems with the learning opportunities. But what I mean is people, if they want to progress, then and they're good, and they know what they want to do, then they should be allowed to progress, and their progression shouldn't be halted by some, missing assessment. And that's why we've cut down to the really important assessments. There will be some trainees who may have had their training disrupted, and they may not want to progress. And I know an example might be somebody who's been very keen on community child health and perhaps wants to do it as a subspecialty. And they did their general paediatrics in ST4, and they did some neonates at the beginning of ST5, and they were really looking forward to doing their community child health in ST5. And then they got redeployed, and lots of the community services stopped. Now, what I'm not saying is that trainee should be pushed through, but what the trainee needs to do is is go to their head of school or training program director and their education supervisor and have a discussion about whether they could progress to level 3 perhaps, but have the training re-provided at a later date, or whether they actually might find it advantageous to be held at level 2 for another 6 months to get that training in. So I think it's about trying to allow trainees who know what they want to progress if they can. But for other trainees, if they're worried about things, the first place really is your education supervisor, followed by your program director. And I think it's fine for me to, make guidance, but the real work, the hard work, is going to be in lots of negotiations and conversations up and down the country, figuring out how to get trainees back on their intended track. And I think the other thing we don't yet know is quite how long the tail of this pandemic will go, and how services will be impacted for a long time. I suppose my message of reassurance is that if the service is going to be impacted for a long time, then we're training people to work in that service. So there's no point in going back to a service which will never arise. If we're not seeing so many patients face to face, then it's really important for us to train people on how to do really good remote consultations, how to pick up cues remotely. So I think it's about being adaptable and not worrying too much about what you might have lost from COVID, but think about how you might get training and how your training might change because of COVID. There's lots of people whose life plans have been put on hold because of COVID. And that's, in terms of people who've had their marriages delayed, or their UPIs delayed. There's people in research projects have been closed down. There's, self-employed people who've lost their jobs or lost their finances. I mean, it's had such a profound impact on everybody that I think lots of people will be sympathetic. I hope they will be sympathetic to all our trainees. But it's a question we all have to muddle through. And in some cases, it will be a bit of a muddle through. Just be patient. We're in it for the long haul. It's a marathon, not a sprint. And so if you felt you've just fallen behind a little bit on that last sprint, there's a long time and a long way to go for you to catch up.
Definitely. And I'd just like to take this opportunity to say thank you for being so clear and honest, for guidance for trainees since the beginning. And I think we were one of the only subspecialties to just be open and honest straight away and give as much guidance as possible.
Yes.
And I know that was really
well. I think that was my intention. I think it's always a bit. There's always a temptation to think, oh well, I won't tell people about our plans just yet because we're meeting with the GMC next week, or we're having a committee meeting the week after that. If we just wait for another 2 weeks. But of course, in life, you have those meetings. It's never quite finalised, and so I just took the approach of let's just say everything early on. And I have a lot of confidence in trainees who realise that what we say is subject to change, it is subject to negotiation, the GMC, and it's subject to what happens with the COVID pandemic. People are mature enough to realise. But what we're trying to do is give you a message of our intention, which is our intention is to support training and support this big sort of impact wherever we can, really.
No, definitely. And it's been really well received. Thank you.
Thanks.
Yeah, I echo that too. So I'm sure if both of us feel that way, then you've managed to reassure and sort of comfort, I suppose, the paediatric trainees across the country.
Good.
I just wanted to say thank you to Stacey Harris and Hannah Davies for recording that podcast for us, and a very special thank you to Dr. David Evans for taking so much time out of his busy schedule to do that for us. Hopefully that's answered a lot of your questions. Anyway, that's it for this week of Dragon Bites. Please join us again next week, where we'll be continuing our series of cardiology lectures from Professor Orhan Uzun. Thank you for listening to Dragon Bites.